Today, I'm going to share something that is very close to my heart, and that is how to optimize spinal anesthesia for the parturient in your obstetric practice. So in this particular lecture, I would like to focus on the fact that spinal anesthesia does predominate, as was mentioned, in obstetrics. And because spinal anesthesia is now used so widely, we may not have the previous awareness under anesthesia, but we have a new kind of awareness. We call it pain or failed regional anesthesia under spinals. And we have under this kind of situations, really need to make good. That means we must never allow our patients to experience failed regional anesthesia. And that's the purpose of this talk. And so my focus in this particular topic would be to help you look at how you can understand the technique and the drugs that you use to make your spinals work 100%. And of course, if you do have collections of obese patients, which I believe you don't, but which is quite an often occurring phenomena in my country, we do have problems with the obese patient, and we have to learn the art of doing ultrasounds with this patient to better locate the spine. And of course, besides the obese patient, there are also other patients with a difficult spine, especially patients with kyphoscoliosis, and we have to figure out how to get into the spine in order to conduct either the epidural or spinals for these patients. What I've picked up here is the rate of general anesthesia going down for this particular country in Nigeria, as you can see, and the rate of regional anesthesia, especially spinal anesthesia, moving upwards. And this is a trend very much seen all over the world, and I'm sure it shows up in the Indian data as well. Because of this predominance of the use of regional anesthesia, we are beginning to see a new pattern in our deficiencies in care. And as you can see, if you compare data in the anesthesia claims between 1980 and 1999, where regional anesthesia became the main focus for obstetric and non-obstetric, inadequate anesthesia or analgesia actually comes up to as much as 11% of the claims compared to the non-obstetric claims. So it is an issue that we really have to put a lot of our attention on so as to bring these numbers down and to make sure our patients get the best of care. And what I have here is actually data from AstraZeneca, and this is their annual reports of failed spinal. All right. And what I have is the arrow from reports from Asia. As you can see, as we move along with the world in increasing our regional numbers, we also have been complaining of failed spinals. And the first thing when we have a failed spinal is, of course, to blame the drug. Why blame ourselves? Blame the drug. And I myself have contributed to 2 of these blames. All right. And each time I will receive a letter from them and they will say, oh, this drug is definitely pristine. It was definitely okay. So I knew that I could not write a 3rd letter, and I decided instead of looking at the drug, I had to look at myself. And that was the beginning of my journey into making what I would say a real in-depth study of how I have failed. And I'm going to share with you those pearls that I have acquired. All right, you do know that the spine curves in this manner, all right, with convex as well as concave curvature. And for the lumbar curvature, you can see the curvature is that of a lordotic spine. That means the spine curves anteriorly. And when the mother is pregnant, this is kind of reinforced. So it is not easy to get into a spine where it is lordotic like this, where the curvature is in such a way that the opening to the intrathecal space is so narrowed. So the most important thing to then understand is, I'm sure all of you do it almost reflexly, is to flex the spine. And when you do flex it properly, instead of allowing the extension to occur, you would see that it does increase in size from there to here. The pearl that I'm going to share with you is, a lot of us just take the pillow that occurs or that is found in the labor ward or in the operation theater, and then just ask the patient to curve on that pillow. I'm going to introduce you to the ball concept. You can see the ball here. In fact, one of my trainees who came from Nigeria was so impressed with this ball that he calls it the Chan ball. Now, this is actually nothing but a beach ball when inflated. If you ask your patient to curve or to hold the ball and hug it like you would hug a kind of a, like how a sumo fighter would hug something in front, all right? And because it is soft, and if they can do it correctly, then you will find that they can curve very much better for you. Now, after all this, you can also, as when you position the patient in this manner, you can also, with your thumb on the correct spot, tell them to push that particular thumb of yours backwards, and they will curve a little bit more for you over that particular area that you want flexed. And you will find that you are going to get a very, very much more flexed spine than you would if you had used a pillow. Now, a lot of us, when we were junior, have always been encouraged, go exactly for the midline. And then when you see how your trainee actually does that, they will go in the midline and then they will follow the spine upwards. Actually, this is the most difficult area because the space is not big. If you just go 0.5 centimeters more lateral, you will find that, you have got more space. But make sure that when you enter that space that is 0.5 centimeters away, just do it at 90 degrees. Don't do it as if you're going up the lower border of the spinous process, all right? And you will find really ample space. So if you are still very stuck to the midline and you can't get it, all right, just go 0.5 centimeters lateral to that midline and go for this space, 90 degrees. You will find you're more likely than not to get in. I'm not very sure how you position your patient, but nationally in Malaysia, all our obstetric patients are done with them sitting up. But you will actually also have patients who cannot be sitting up for you, those with prolapsed cord. And you'll be surprised if I were to tell you the whole country in the Philippines have providers all doing in the lateral position. If you're actually doing in the lateral position, you have to be mindful of the kind of pelvis a female patient actually has, all right? Most of them have what we call a gynecoid pelvis, unlike the android pelvis of a male. And because of this gynecoid pelvis, if you actually put them on the trolley like this, you will find that you can't get the correct place to get in because this anatomy is going to be distorted by the gynecoid pelvis. So maybe a slight hang of this pelvis or this spine away from, to take the pressure away from this gynecoid pelvis will allow you to better enter the intrathecal space. Now, the other important thing to remember is how to steady the spinal needle. I always see my trainees not realizing, especially when they're doing epidurals or spinals, not knowing how to steady the needles in the presence of a moving mother. There are more emergency cesarean sections than elective. You can check all your data and you'll find, because emergency periods cover a longer period, more patients come in during that particular period. So you're going to encounter more patients who are not going to be able to keep steady for you. So you must, while you're doing the procedure, realize that you have to move along with the patient once your needle is actually in the intrathecal space, especially during the injection. Otherwise, you are going to get out of that space and some of your drugs may be dispensed away from the intrathecal space. A good spinal means that you have actually put in the amount of drugs that you've calculated into the intrathecal space and nowhere else. Now, once you got into the intrathecal space, you have to be very honest with yourself. If you are totally in the intrathecal space, you must experience free flow while you are aspirating the CSF into the syringe of drugs, because that's how you're going to say, yes, I'm in the intrathecal space. If there is free flow and excellent aspiration, keep your hand steady, inject your drugs. All right. And then, of course, towards the end as well, again, you have to check whether there's free flow and excellent aspiration. Unfortunately, when you come to the aspiration towards the end, if it is not excellent, you will just have to tell yourself, I may have moved the needle somehow. There's nothing to bail you out. But if at that juncture, towards the end, you have excellent flow, you can pat yourself on the back and say, look, it does look as if I have got all the drugs into the intrathecal space. Obviously, a lot of us assume if I have CSF coming out, I'm in the intrathecal space and nowhere else. Not true as well. This is the ideal spot you want. You see, the outlet of the needle is not at the tip. It is about 0.5 centimeters away from the tip, and that's where it is. And you want your needle outlet to be in the intrathecal space like here, not like here. You see, over here, if it is malposition, yes, you can get the CSF coming out, but you are not going to get a free flow. And then if you inject at this juncture, some of the drugs will get in and some of the drugs will be in the other space, which is very likely to be the epidural space. Then you're going to experience inadequate drug dosage and the block may not work or may work for a while but of short duration. So be mindful of the fact that your drugs may be anywhere, although you can tell yourself the CSF is there. It is a definitive indicator that I'm in the correct space, but never all the time, especially if you are not mindful of the fact that you have to be fixed, locked onto the patient's body with your hand movements, so as not to allow the drugs to be dispensed anywhere or to come out or to experience movement of this outlet away from the intrathecal space. Now, if you happen to be here, because as I said, when you have connected, originally you were here, free flow. And then when you connect, because your hand movements was not perfect, it has come out here, and then you realize it is not free flow and the expiration is not excellent. You have to be honest with yourself. This is the good time as any to tell yourself, if I'm truthful to myself, I better do the correction. And how do you correct? Don't worry, at this juncture, the easiest thing to do is let the needle be there, put the stylet back and push it right inside. And then you try again. That means take the stylet out and then see whether you got free flow. Okay, connect again, this time very mindful of how you move your hands and lock it against the body of the patient and then aspirate. You can only inject if there is free flow and excellent aspiration, as I said. As I said, I do not know whether you do it in the upright or lateral position. And for those of us who are committed to the upright or the sitting position, as I say, in the whole country in Malaysia, we still have occasions to do the lateral position in the prolapse cord situation. And this is something that I would like you to be mindful of. The CSF that comes out more slowly if the patient is in a lateral position. This is actually data that was never published, but came out from one of my trainee's study where she determined the time from first CSF appearance to CSF appearance to the needle hub itself. And she timed it in seconds. As you can see, it takes a shorter period in the sitting position, whereas in the lateral decubitus or the lying down position, lateral position, it is 17 seconds. So a lot longer because the pressure head in the lateral position is lower. Okay, so again, if you're doing it in lateral position, do you put the patient in the left lateral or right lateral? I did again ask this question when I was in the Philippines, and all of them said they would go for the left lateral. Maybe I should probably ask you, but I'm going to save time and not do so. But this study will tell you how to position the patient. This was a study done as far back as 1987. So 35 patients were scheduled for cesarean section. They were randomly assigned to either the right or the left lateral position. And then after the spinal was inserted, they put the patient with a wedge under the right hip. So what they did was then they were looking at the segmental levels of analgesia between the two groups, and they found no significant difference between the two groups at any stage. So you're going to say, YK-chan, what then are you advocating one position over the other? So what they do with the data was very interesting. They actually now look at all the right-sided group patients. That means those who were placed in the right lateral, and they found no further analgesia was required. But those placed in the left lateral, they need postural manipulation to encourage the spread of analgesia. So what we are then now going to look at is to relook at their data where they divided the patients now, whether regardless of how the patient was done, whether left lateral or right lateral, they look at the no intervention required against the intervention required. Very interesting. Those patients who did not require intervention, by the time we have 2 minutes was up, they had already gone up very high up to the thoracic level, whereas those patients who needed intervention, they were very slow to start in terms of progress upwards. This is something, if you have got all your drugs in the intrathecal space, if they don't work in 2 minutes, you are heading for trouble. And many of my trainees are very impressed when I pointed that out to them. They said, look, you've done very well. Within 2 minutes, the patient is complaining of, numbness, tingling, whatever in the lower limbs. And if you check at this time, they have already gone up to about T8, and you should be very happy. You've got a very good spinal already done. But if you are struggling at this stage, when the patient says, no, I don't feel anything, I'm still able to move my lower limbs, you might be heading for trouble. Your drugs may have gone not into the correct space, but probably into the epidural space as well. All right. And you will see how slowly the progress is for those who don't get adequate drugs into the intrathecal space. The moral of the story is right lateral is where you place the patient. If you're doing in the lateral position, right lateral, do the spinal, and then after that, allow the patient to become spine with a wedge on the right hip, and you will get the better spinal compared to placing and doing the spinal in the left lateral tilt. Now, I'm going to share with you 2 scenarios and lessons I've learned. So I had this particular patient, 33 years old, who requested for a change of anesthesiologist. This was one of my private patients. You see, in where I practice, I've also got the privilege. I no longer enjoy that practice for private patients now, but many years ago, I had this privilege, and this particular patient was supposed to be done by this obstetrician, and this obstetrician alerted me and said, look, this patient wants a change of anesthesiologist because I have failed her 2 years ago. So I, like most of you would, decided, okay, how have I failed her? So I went and looked at the notes. I had actually recorded that the patient had more pain on the right side. And I have offered her general anesthetic for the failure, but she declined. So all I could give her was Enterols. So when I saw her, I discussed the issue with her and I said, look, we do have another anesthesiologist whom you can use, and I'm happy to get her for you. But she declined. And that was the worser of the two offers, because it then made me feel that I have to do a better job. And if not, I'll be defined as a total disaster. So what did I do differently? Obviously, I knew what has happened. I needed to give more drugs. And what happened also was, because it was a sitting position, I'm a bit of a fast worker as well. What happened was I did the spinal. She was not a very high BMI patient. She was exactly like me. So I did the spinal and very quickly allowed her to tilt to the left. So she had more drugs on the left side and less drugs on the right side, which explained why she had pain more on the right side. So this time I decided, okay, more drugs, more fentanyl, and I would put her supine for longer before the tilt was instituted. So in the end, it was a success, and I was so grateful that everything went well, and I knew what went wrong the last time, and I've corrected it. So both husband and wife have offered to retain me for a spinal in future, but obviously I've dropped out of that particular scene. The other lesson also from a spinal was from an in-evidence spinal. Again, this was one of my private patients. She had requested for an epidural while in the labor ward, and her pain score was around 6/10 at that juncture. So 10 minutes after the test dose of 1.7 mils of 0.75% ropivacaine, this is actually equivalent of the test dose that in terms of dosage, she said her labor pain was relieved from 6 to almost 0, but still able to move both lower limbs. I was actually quite surprised, because I was usually after this kind of test dose with an epidural with a pain score of 6, the pain may not be totally reduced. But so I was telling myself, it did look like this has gone into the intrathecal space. So what I did was I omitted the first top up, and I continued with an infusion of very much lower dose, 2 mils of 0.1% ropi with 2 mics per mil of fentanyl, and I placed her in the left tilt. And because I had to leave her, I got one of my younger trainee doctors to sit with her, telling him that this particular patient had an intrathecal drift of the catheter, and I am treating her as such. So 1 hour later, the patient complained to the provider that there was more pain on the left side, but no pain on her right side. Remember, I actually was using an infusion of 0.1% ropivacaine. All right. So here she complains of left side pain, but no pain on her right side. So my trainee was very confused and said, Prof. YK, I think your epidural has gone to the right side. So I said, no, this is not an epidural anymore. It's an intrathecal catheter now. So what exactly was happening was the ropivacaine has actually, being a hypobaric, because of the way we dilute, hypobaric solution has floated, because I placed on the left side, has floated upwards. So the right side is pain-free, the left side is not. So what I did was I placed her totally on her right side now. And of course, the drugs will now float upwards to the left side, and she had no more pain on the left side. In the end, actually, she also delivered by cesarean section using dosage I would give via intrathecal dosage with very much reduced dosage and not treating it like an epidural. So that brings us to the subject that all of us as providers of spinal anesthesia must be aware of: density, specific gravity, and baricity of local anesthetic agents. Something if we do not know, we will get into trouble like this, the last patient that I described. Of course, one knows that density is weight per volume. Specific gravity is density relative to water, and baricity is density relative to CSF. So you must be mindful of the different baricity of our drugs as well. All of us use heavy marcaine because we want to increase the density of this drug so that it actually condenses into smaller volume and stays within that small volume to give you the block that you really need. So especially if you're sitting your patient up, and especially if they're sitting down too long, most of the drugs will actually go down to the sacral area. And when you lie the patient down, it may not reach high enough. So I would encourage your patients, especially for obstetric practice, to sit them for your spinals, but then on the other hand, be mindful of the density of the drug. So we're just going to go through some of these features. The density of CSF is about 1.0001 to 1.0005. Specific gravity is around there as well. So isobaric solutions are within about 1. There's no added glucose, not influenced by position. Hypobaric is when the drug is lesser than that of CSF, and hyperbaric, which is what we do with our heavy marcaine, you will find that we have added dextrose around 6% to the drug itself to increase the density so that the baricity is increased and you want a lot of it to float downwards itself. Very important to also know how much drugs to give to the patient. On the average, most of our patients are about 5 feet or thereabouts. 4 feet is really an exception. I'm not sure, maybe in the subcontinent of India, more of your patients are of shorter height. But this study that was done in 1991 was used to determine actually whether we should give more drugs when the patient is taller and less drugs when the patient is shorter. And they have found in this particular study, as far back as 1991, that with a fixed dose of spinal anesthetic drugs, 12 milligrams of hyperbaric marcaine, there's a significant correlation between vertebral height measured from C7 to iliac crest and the level of anesthesia. So if you think about how much you should give, and you look at your shorter colleagues as well as your taller colleagues, you will find that their vertebral height is almost the same. So if under that kind of arrangement, the average patient has the same vertebral height all around. If you look at all your providers sitting around a conference table, you will never be able to select the shorter patient from the taller patients. All of them, when they're sitting down, their vertebral height will almost be the same. And I'm going to tell you this particular story. Now, I mean, those of you who know me may say, wow, you are actually very tall. So how can you have a sister that's taller than you? I do have a sister that's taller than me. She's about, I would put it as about 2 or 1.5 inches taller than me. And we used to share a car. And each time I hand the car to her, I will get a scolding. And why so? She said, you are actually putting yourself at risk. You're sitting too close to the wheel itself. I said, look, I can't reach the pedals. That's why I need to move the seat forward. And, you know, to her, it is too far forward. But to me, it's just about the right height, or rather the right distance to the pedal. And why so? So that 1.5 inches difference between her and me was because she has longer legs. So what I want all of you to understand is your sitting height against the total height itself as you progress from infancy to teenage as well as to adult food, you will find that the ratio actually decreases. The sitting height has become lesser and lesser of the total height compared to, that means when you are younger, your legs are shorter. But when you become older, your legs relative to the sitting height is actually longer. So between me and my sister, we have almost the same vertebral height, but she was taller than me because her legs were longer. So when you measure body proportions, tall children have relatively longer legs and short children relatively shorter legs. So in the adult population, when you look at your colleagues, in fact, maybe I should have included that picture. If you now, when you go back to the theater, select one short individual and another tall individual, and you normalize the two individuals by asking them to normalize their iliac crest position. That means both of them now have normal iliac crest position. You will find that then they become of almost the same height, because the taller person would have to lower himself or lower herself and reduce the height of the leg. You will find, very interestingly, the vertebral height is the same for a lot of us. So what I'm actually trying to then grapple with is whether the patient is short or tall, the vertebral height is more important than the total height in setting the amount of drugs you should be giving to your patient. And this was again in 2017 reinforced by this study that came out from Taiwan that says that the determinant of the correct dose is abdominal girth, vertebral column length in the spread of intrathecal hyperbaric bupivacaine. So these are the only two parameters that determine how much drugs to use. And as I say, if you're using heavy bupivacaine, you should lie the patient down if you're doing it in the sitting position, so as to allow some of the drugs to spread upwards and not just go into the sacral area. Of course, increasingly, you may also find with progress in medicine, a lot of these kyphoscoliotic patients, and of course, also the obese patients become something that we encounter in our practice. So you do get the difficult spine, and that behoves all of us to learn how to use the ultrasound for the difficult spine. And I'm sure a lot of you have also used ultrasound for other practices, especially in intensive care. But if you're using it in obstetric practice to look at the spine, the probe that we should be using is the same probe that the obstetrician used. So if you do not have the resources, just go borrow it from the obstetrician, and then the two of you can actually use the same probe, because they also use the curved probe itself. Unlike the intensivists, when they're looking for vessels, they use the linear array probe. The reason why we're using the curved probe is because it has got deeper penetration, but unfortunately lower resolution. But after a while, you begin to learn the anatomy, and I'm not going to tell you how, but more important is to be able to get where the dura is, as well as where to get the posterior longitudinal ligament is, and this is where the cord or the nerve roots are going to pass through. So the idea is, I know they say there's this bed swing appearance that you are supposed to be looking at, but with the ultrasound picture that we have, I just tell my juniors, oh, just look for what I call the equal sign. Two lines that will appear when you put the probe at the correct area, and you will see this sign. In the paramedian view, which is this one, you will see the dura as well as the posterior longitudinal ligament as well. But this one is when you have the other way around, and this will be very obvious. And there's a certain way of marking it, and the person who is marking must not be the same person who is looking at the ultrasound picture to anchor it, and also to go down to that level of the probe, look for the midline of that probe to put the marking in on the skin. So this is the transverse view that I was telling you about. Now, when you do see the equal sign somewhere here. The person who is marking must go down to the level of the probe and look for where the midline, this is where the midline of the probe is, and then mark it on the skin of the patient away from the area that is going to be used, because we don't know the contents of the pen that we are using. We don't want any of this poison to be introduced into the intrathecal space. So marking must be away from the midline itself. And parallax must never come into the picture. So the person who's marking must do it without parallax being introduced. Similarly, the person ultimately who is going to put the needle in must then must avoid the parallax again. That means must go down to the level at eye level and see where you are putting the needle against that particular level that has been identified for you. Early on, this is where the spine is, and this is where the intrathecal space is, and this is where you want your person who is drawing for you, delineating for you, to mark at the level of the skin this particular point that coincides with the midline of the middle of the probe. When you are here, you will see the posterior longitudinal ligament and the dura. So you can see the bat's wing appear, whatever you call this, the bat's eye view or whatever, somewhere, flying bat pattern. But normally our probes are not so fantastic to show you all the facet joints and all that. All I can see, if I can see already these two, I'm very happy. These two lines is the most obvious. I call it the equal sign. When you meet your kyphoscoliosis patient, you must actually know that those patients with kyphoscoliosis have what we call rotation of the spine. So if you are palpating these patients from behind, you might actually mistake this particular transverse processes as the spinous process itself. See, the spinous process would be here. So when you do the ultrasound, you must know the rotation. And then if this is the spinous process, then go from the other side and go in from there to do your epidural or your spinal itself. So rotation must be taken into consideration, and you have to work out mentally how to position your needle to get into the epidural or intrathecal space for the kyphoscoliotic patient. In summary, our spinal technique needs to be improved, and there's lots of room for improvement. I'm glad to have shared those gems that I have learned along the way. It's been a long journey since the two letters went out to AstraZeneca. And it is important that you should flex the patient with the correct arrangement, correct curvature really helps. And always tell yourself and be honest, is there free flow or not? And that's the good time. If there's no free flow or no good aspiration, do it again. This is the best time to redo by putting the needle in. If previously you had the CSF coming, you're in the space, but without a free flow, please do not inject. I don't really think that there's a lot of literature telling you this, but it is my honor to be able to share with you this good tip on how to make sure you get a spinal 100%. And you must learn the art of ensuring that the needle stays with the mother. And any movement in her part should never allow the dislodgement of the needle and should stay 100% again in the intrathecal space during the injection. And it's important to know the baricity of the drug so that you can refine your technique and be able to explain some of the phenomenon that you get when the drug goes away or not in the correct space. All right. And it is important to remember to put in the time and the effort to master the use of ultrasound for the difficult spine. Obviously, we're not going to ask you to do the ultrasound when you have difficulty with the spine only. Do it with a normal spine. But even if you can do it with a normal spine, you must learn the art of ignoring the fact that you can still palpate, because we need you to actually look at those points that are important, like avoidance of parallax error, to help with, the use of the ultrasound during difficult times. You would notice that I've got 2 emails. You can actually connect with me anytime. I'm very happy to be of assistance to any of you in a difficult situation. And my motto for all providers in obstetric anesthesia is, and will always be, the 2 lives do matter, and we must always do something right for them. All right, with that, I would like to thank you for listening in.